All right, I'll go ahead and kick us off here since we're just about noon. So definitely have some familiar faces in the room and at home or wherever they may be catching a Zoom. But I'm Elaine Swain, the Executive Director for Mental Health America of Spartanburg County. Welcome to our May educational series, partnering with iTrust Wellness. So we thank you all for being either here in person or watching on the computer. I'll be monitoring the chat, so feel free to ask questions if you're on Zoom. And of course, we'll have some time for questions for those in the room. I'll go ahead and turn it over to Anna now. If you'd like to talk a little bit about iTrust, I'm going to start here and introduce your CEO here.
Yeah, definitely. Well, thank you so much for having us. My name is Anna Ballou. I'm the Community Relations Coordinator for iTrust Wellness. We are a locally owned and operated psychiatric practice treating ages 18 to 75. We are founded by our CEO, Steven Krozer, who's going to be presenting to us today. He's a board certified psychiatric nurse practitioner. We do have 4 brick and mortar locations in the upstate, including one in Spartanburg. It can also provide virtual services throughout South Carolina. We are in network with commercial Medicare and TRICARE insurances, and we schedule initial appointments in an average of about 2 to 4 weeks. So I have plenty of materials back here that you're welcome to come grab, or if you would like digital copies of anything, if you just registered for today, I'll be more than happy to send a follow-up email containing all of this information and answer any questions you all may have. So thank you so much. I'll turn it over to Steve. This is Steve, our Chief Executive Officer of iTrust Wellness. He started iTrust in 2017, I believe, so closing in on 8 years, which is hard to believe, but he is a fantastic resource in both the clinical, the business, and the educational space. So I think he will be a fantastic presenter to be speaking with you all today. So I will turn it over to Steve. You want to take it off?
Thanks, Anna. So I guess this is the time of the year where people are struggling with allergies and sometimes struggling with some insomnia. We have the clocks going ahead and clocks kind of turning back. So spring ahead, fall back. In mental health, that's actually the 2 busiest weeks that iTrust has. So we oftentimes notice when our folks with depression or sleep issues or bipolar disorder set their clocks back or move them forward, that's actually one of the busier times of the year for us. So I felt like this was a very relevant, very practical presentation. You guys should be able to learn stuff, not just on the medication side, but also just practical tips, a little bit about our REM cycles, a little bit about sleep in general, and then hopefully maybe even sleep better yourself by the end of this. Just as a show of hands for the folks in the room, does anybody struggle with falling asleep, or has anybody had insomnia before? Okay. Is it secondary to something else, or is it just, okay. So we'll talk about primary insomnia, we'll talk about secondary insomnia. There's causes of both. We'll kind of get into basically the different sciences of sleep, what are different REM stages, and then we'll kind of conclude with some treatments and some recommendations that we can kind of look at, okay? So we'll keep this really practical. This is actually a CME approved presentation, so if anybody wanted to submit this for continuing education, feel free to. But again, we're going to be really talking about sleep hygiene, holistic approaches, medical treatments that are available, psychotherapy, and then pharmacological treatments for sleep as well. So let's define sleep. So we spend 1/3 of our lives sleeping. So we want to get high quality sleep, right? So I always have a kind of mantra that I live by, that I invest money in things that exist between me and the floor. So tires on my car, bed that I sleep in, pillows that I lay on. These are all really important things for our comfort and a restorative energy at the end of the day. During sleep, this is a absence of wakefulness, and by the loss of consciousness of one's surroundings. It's accompanied by a typical body posture. I don't know if anybody is sleeping upside down or anything crazy like that, but we're typically laying down with our eyes closed, and we oftentimes have dreaming or changes in the brain activity, physiological functioning, and it's made up of cycles of REM and non-REM sleep. What's really cool about sleep is that even on fMRIs, we can see how the brain is changing depending on being in a sleep state versus being in an awake state. And we'll see some brain scans in just a few slides in terms of that. So why is sleep important? Well, we need it to live. We need it for life. We need it for growth and brain function. We need it for physical health and mental well-being. So without really good quality sleep, we're not going to have, really that restorative energy at the next day. That's kind of, what we need to target. Do we need to pause for a second for video? We good?
We're just trying to make sure your slides are visible to those folks at home. In
Okay.
case they may not be correctly, so sorry about that.
You're good. I can pause for a second, and we can continue forward from there if you'd
I
like to.
appreciate it.
While we're waiting, if everybody in the room can see this slide here, this is a really interesting, just how does our brain look while we're sleeping versus how does it look while we're awake? If you don't have good quality sleep, if you have problems sleeping, you can see just how different the brain is looking actively versus, while we're in REM state. Does anybody know what REM means? Rapid eye movement. So rapid eye movement is the stage 4 of sleep. So our brain will kind of talk about the stages as they pull up the slides, but we have different stages of sleep that we cycle through. Stage 1 is kind of like you're entering into the gateway. Stage 2, kind of dipping into a further dreaming state. And then 3 and 4 is really where we get our deep and restorative sleep. So in that stage 3 and 4 is where we have REM sleep, rapid eye movement. It's also where we have dreams that are associated with that too. And this is not something that I have in the slide deck, but again, I want to give the IT people some time. So what is anybody ever hear of lucid dreaming before? Does anybody have a lucid dream that they've experienced before? Okay. Anybody interested in learning how to lucid dream?
Maybe.
Okay. So lucid dreaming is basically you are aware that you're dreaming. Kind of a cool thing if you think about it, because if you think, of a dream, it's kind of a fantasy world where you're kind of in control of what happens. Sometimes I guess you can feel like your dreams are in control, but really the definition of lucid dreaming is you're in control of your dreams. If you wanted to get better at lucid dreaming, you want to keep a notebook by the side of your bed. And every day when you wake up, you want to write down anything that you remember from when you sleep. So it starts to put your brain, your body, your mind into a better memory state. So after you wake up, keep a notebook next to your bed, write down anything you remember from your actual dream. And then over time, you're going to start to notice that during the last hour or 2 of sleep, in the last REM cycle that you have, you'll start to be in a little bit more control of your sleep. So helpful tip there. I'll give them a few more moments on the IT side.
Hey, I have a couple questions.
Go for it.
What percent roughly of people who come to see you are coming primarily due to sleep issues?
It's a good question. I would say it's probably relatively low. The reason for that is typically if somebody is having sleep issues by the time that they get to us, they've probably already solved it in some way. Whether they're self-medicating with drugs or alcohol, whether they're taking over-the-counter sleeping supplements or things like that. Having an actual acute insomnia episode that's kind of long enough that by the time they get to a specialist is still untreated. Obviously, that's something that would be really unusual because they would just have that really sustained period of time. During the time that the patients are working with us and seeing us, I think it comes up a lot because once you're established as a patient, obviously you're not having to go through a referral process. You can basically schedule an appointment a lot sooner. Let's say most, if any, patients will have sleeping issues from time to time. That's probably the #1 thing that as a clinician I would target. So somebody comes in, they're complaining of anxiety, depression, multiple different types of symptoms. I go back to Maslow's hierarchy of needs. I go to the bottom of the pyramid rather, and I go right to sleep. I go right to nutrition, appetite, water intake, all of those things. Because we don't lay a good foundation, we're never going to feel better overall. So sleep is really foundational for that.
And sleep disturbances are a symptom of many different mental health disorders.
Correct. The sleep is a gateway into your mind, right? It's where dreaming occurs and so on. So kind of like the gut-brain biome and the gut-brain axis, I would say. If you're not dreaming, good thoughts and you're not sleeping with high quality, it's probably your brain, your mind's telling you something that's kind of wrong in some ways. So long story short, I think, yeah, it's a good point. Oftentimes it's not the acute issue. It comes up as kind of a secondary issue throughout treatment, but nonetheless extremely important to address. Typically also people wax and wane with their sleep, where sometimes they have more periods of insomnia than less. So it's not usually like the primary issue that people are facing. Oh, okay. We're doing a little IT stuff here. But anything helps you with your insomnia.
Meditation was one of the greatest things that helped, just to relax. Then go to sleep in trazodone.
Trust, yeah,
Yeah.
it's an effective one. Yeah, mindfulness and sleep hygiene. We've done a lot of research on blue light blocking glasses, so oftentimes a lot of people are using their smartphones or computers before they go to bed. Anything that you basically use that's a blue light emitting source within about an hour of bed tricks your brain into thinking of looking at sunlight. So you have two sleep hormones that basically are kind of circulating through your body. Your awake promoting hormone is called cortisol, and your sleep promoting hormone is melatonin, obviously. We've kind of messed up our melatonin production, I would say, because when the sun went down historically as humans, melatonin production would start to ramp up. Now that we have modern lighting, computers and screens, our brain really doesn't know when to turn off and when it is time to go to bed. So oftentimes that's where the issues of insomnia come up. So if you ever felt like you ever kind of push through that feeling of being tired, kind of like getting a second wind. So that's where your body naturally is producing melatonin because it's preparing to go to sleep. And then pushing through that second wind basically tells your body that you're in a fight or flight state. And that's when cortisol production starts kind of ramping up again. Right, like we talked about, stage one is our entrance to sleep. This occurs for about 5 to 10 minutes. This is where we're basically nodding off into sleep. This is not something that, again, is really sustained. This takes about 5 to 10 minutes, like I said, so we basically breeze right through that one. Stage two is onset, so we start to see actual vital sign changes. We actually start to see the physiological changes of sleep. That's when you probably are not aware that you are falling asleep. Again, if you were able to lucid dream at this point, you would, again, not really be aware that you are even in a dreaming or a sleeping state. Your breathing will slow down, your heart rate will slow down, your blood pressure will drop. These are all very normal physiological effects of sleep. Stage 3 and 4, like we said, your vital signs are settling into more of a sleeping pattern. You actually have the release of growth hormone during this stage as well. And this is where sleep becomes more of that restorative type of phase for our body. Oftentimes there's been some research about Alzheimer's disease and dementia progression. And oftentimes it's associated with the beta amyloid plaques, but they're starting to do more research in terms of if somebody doesn't get adequate and good quality sleep, basically their brain isn't able to kind of clean up the different, damaged oxidized cells that have been kind of accruing during the normal operating hours of the day. And so that's where we start to see the vasculature changes that sometimes occur with memory disorders. We also have the REM and the dreaming sleep during this phase as well. Okay. So stage 3 and 4 occur about 90 minutes after falling asleep, and the cycle is kind of true to that. If anybody has ever felt like they were really groggy when they wake up during the morning, it's probably because they woke up in the middle of one of their sleep cycles as opposed to the end of it. So what you really want to do is you actually want to time the kind of duration of your sleep to be on a 90-minute calendar or a 90-minute clock. So for example, 1.5 hours to 3 hours, 4.5 to 6 hours to 7.5 hours. You don't want to basically wake up at 7 hours. You want to wake up at 7.5 hours. You don't want to go till 6.5 hours. You want to try to get 6 hours of sleep. You really want to try to time it so it's on that 90-minute cycle. Otherwise, you may wake up and feel that feeling of grogginess during the morning time. So there's several apps that can help us do that. but also if you're just cognizant of how long it typically takes you to fall asleep, and then enter into that stage of sleep. Basically 90 minutes is kind of the golden rule there. REM can last from 10 to 60 minutes. So again, that's why that 90-minute window is so kind of widespread. The grogginess, of course, comes from waking up in a REM sleep because you're basically in the deepest part of your sleep. If you're startled awake, you're obviously like, again, going from kind of 0 to 100 at one period of time. So keep that 90-minute rule in mind. And then, of course, during the night, we're kind of going through an average of about 5 REM cycles altogether. So 4 to 5 REM cycles is typically what most adults go through. They get longer as the night goes on. So typically in the beginning of the night, this is why you probably remember dreams closer to the end of the night, because your REM sleep cycle is longer overall. Okay. How much sleep is needed? Are we getting this amount of sleep for the folks in the room for your age range? Show of hands. No, okay. All right, I typically function best around 6.5 to 7 hours of sleep myself. Everybody's going to be different. Like some people are total grouches if they don't get 9 hours of sleep. Some people can't function if they don't get 8. Everybody's a unique person overall, right? This is a great age range though, and as you can see, younger people need more sleep. As you get older, it starts to kind of diminish how much sleep you need. So that's generally the rule of thumb that we follow. So what happens when sleep doesn't go as planned? We get insomnia, right? So let's talk about insomnia. So that's the most common sleep disorder. We have other sleep disorders called obstructive sleep apnea, restless legs, narcolepsy. These are all things that a sleep specialist can help us diagnose. So myself in the mental health field, I work very closely with sleep specialists. So I would recommend to any therapists that are listening or in the room here, please do refer to a psychiatric specialist first when it comes to insomnia or sleeping issues that your patient is experiencing. Because what we want to do is we want to rule out for any underlying prodromal bipolar disorder or symptoms of something like a depression or an anxiety that's causing the insomnia. And once we rule those things out, then we can, of course, again, refer to a more specialized care to do a sleep study for sleep apnea or narcolepsy or so on. We want to understand that basically the time frame that the patient is suffering from insomnia, and we want to understand the cause. So we want to know when it's happening and what's happening. Working as a team will allow us to do that as fast as possible. Okay, so acute versus chronic, these are two definitions that we're probably familiar with. Acute insomnia is a stressful event, so a death in the family, for example, or some sort of tragic event that is now causing you to lay awake at night. Pretty self-explanatory on that side. And then, of course, chronic insomnia, if you do require taking sleeping medications or routine sleep treatment, it would probably be not a far stretch to say that you have a diagnosis of some sort of chronic insomnia that you're suffering with. So it's something that just kind of being noting on the different vocabularies here. And again, we had spoken about this a little bit earlier. There's what's called primary insomnia and then secondary insomnia. Primary insomnia is basically you have sleeplessness that doesn't result from something else. So I'm just having insomnia because I do. Secondary insomnia is because of an underlying health issue. So for example, let's say that I had a urinary tract infection. So I would need to use the restroom more during the night. So that would cause me to have insomnia and be, going into the bathroom all night. Or if I had hyperthyroidism, that would cause me to have basically kind of a boundless sense of energy. And that's a medical etiology that's causing that insomnia. So when you're a therapist and you have a patient that's complaining of sleep, of course, you want to go through your psychosocial factors that are going on with the patient. You want to say, what does your bedroom look like? You want to ask, who's sleeping with them, that type of thing. Oftentimes it's that they have 8 dogs in the bed. That's the main issue why they can't fall asleep. But once you get beyond the psychosocial factors and you can't point to anything specifically, that's where you partner with the psychiatry folks to say, all right, is this secondary to something else? Is this primary? And then from there, we can kind of do other sleep disorder rule outs as well. Insomnia is very prevalent. 1 in 3 adults in the US suffer from it. Many times I have, I'm sure everybody in the room at time to time, different seasons of life, of course, carry with them different levels of stress. Women have a 40% higher chance of having insomnia than men. We know this is just the way that women's brains are wired. Men, I am a simpler wired creature when it comes to emotions and emotional processing. And that's not saying there's any advantage or disadvantage on that. It's just simply there is more emotional circuitry in a woman's brain, which can inevitably lead to more rumination and more insomnia at night, of course. And that's why we see higher diagnostic rates for women. 35% of US adults say they sleep less than 7 hours. Again, this could be secondary to many different factors. A lot of times I actually find that the reason that patients are not sleeping is because they're consuming caffeine or stimulatory supplements too late in the day. So a cutoff that I think is reasonable for caffeine is don't consume caffeine past 3 p.m. If you are suffering from insomnia, everybody processes these supplements a little bit differently, of course. So 3 p.m. is a cutoff for caffeine for your patients that I would recommend. And 7 hours is the optimal amount of time for cognitive performance and mental health. It was basically diminishing returns. If you got less sleep than 7, it would be worse cognitive performance from there. Okay. If you're having insomnia, we can extrapolate. There are short and long-term effects of that. Again, overall total body system, you're going to have a weakened endocrine, immune, cardiovascular system, your neurological system. Sleep quality is just, again, can't kind of stress it enough how important it is baseline for our patients. We had mentioned briefly about Maslow's hierarchy of needs. Where I like to start all of my treatment is, again, in this physiological needs section. And we really want to address food, water, shelter, and sleep for all of our patients to begin with. I like to say that I can prescribe medications, I can prescribe basically pills, but without skills, there's really no kind of follow through that happens from there. So you need the pills and you need the skills in the same way that you need sleep, you need water, you need adequate nutrition. Any therapeutic gains that are made will not be persistent. Any medication gains that are made will not be persistent unless we address the basic needs that the human body has. And this is the most important thing in any psychiatric diagnosis and any treatment that we can offer to our patients is the word time and basically timeliness. So I would like to say, as a therapist, as a prescriber, as somebody that's listening online here, we definitely want to make sure that we're providing timely access to treatment and we're not letting our patients suffer with kind of that insomnia period of time for too long. Let's make sure that we're being decisive in terms of getting them referred to the right folks. Okay. So what do you have the time to screen for in your visit? Are you the best professional to treat insomnia? This is actually a really good question to ask ourselves. So let's say, for example, I had a referral from a therapist. And again, I've done my biopsychosocial screenings. I've done my rule outs for depression. I've done my rule outs for anxiety. I've done my rule outs for depression. I'm not going to go ahead and continue that patient at our practice and try to be the primary treater of insomnia. I'm going to pull in a sleep specialist at that point. And this is, again, kind of the thought process down the line as well. So if I'm a therapist sitting in a chair, my client is complaining to me about sleep. Again, the timeliness of the referral is something that I want to stress here, because oftentimes the main predictive factor of not having a successful mental health treatment is the fact that we've waited too long. And oftentimes, by the time that somebody is referred to us, not even related to sleep, but just in general, they've probably failed like 5 to 6 medications from a primary care doctor. And it's far too much time that they've been suffering with symptoms, and we want to encourage that promotional language around just refer earlier so they can get in front of the right professional at the right time. Okay, so let's talk about how do we identify potential causes and diagnoses contributing to insomnia. So I like to start as high level as possible and then get more specific. So let's look at the patient. Is there anything immediately that comes to mind that can be the cause? So is this person very overweight? You know, if so, do they suffer from obstructive sleep apnea? Is there any, biopsychosocial factors that are extremely kind of prevalent in our interview with them? Did they just go through a divorce, for example, or did they just have a death in the family? These are things that will inevitably and normally cause some level of insomnia, not the fact that we don't want to encourage treatment for it, but we can predict that there would be a normal amount of that there as well. And then again, refer that patient sooner if you feel like you're not the best professional to work with them. So here's an example of an insomnia screener. This is something that y'all can find for free online. This is a journal and also a Likert scale approach. Describe what types of sleeping issues you've had. Would you rate your sleep quality overall? How many days do you feel rested when you wake up? These types of screeners are what is our objective information when it comes to mental health. Nowadays, we do have wearables. I'm wearing an Apple Watch myself. I can track my sleep now with some of these wearables. There's Aura rings, there's Apple Watches. You guys may know of others as well. But there's ways of tracking sleep through apps and data. But actually asking our patient and getting to the bottom of their subjective interpretation of their sleep cannot be really replaced in any way. We have to talk to our patient and ask them these important questions. If I was to do a referral to somebody to manage somebody's insomnia, I would want to show them this type of screener as well, to show them that this was kind of the due diligence that I had already done. Again, you can find out things very quickly, like alcohol beverages, caffeinated drinks. These will really be indicators that somebody has a very low hanging fruit to treat before even considering medications. Some examples of questions here. Really important ones to highlight here are going to be your nighttime routine. Tell me about your electronic usage at night. A lot of patients that I have, they're kind of subjected to doom scrolling at night before they go to bed. So oftentimes I have patients that are like, I can't sleep for anything. I can't get my mind to shut off at night. And we get into a conversation and it's like, all right, well, describe the last hour before you go to bed. It's like, okay, well, I eat and then I go on the couch, then I pick up my phone and then I start scrolling on Instagram. I'm like, okay, well, how long do you do that? They're like, I think about like 2 hours. And then I'm like, okay, what happens then? And they're like, well, I try to go to sleep. I'm like, okay, well, let's talk about like how that's not going to work. Again, the blue light that's emitted from our electronic devices, the fact that probably anything that you're scrolling on your phone is going to trigger you in some way to have some sort of, emotional reaction, whether it be positive or negative. We really want to train our patients in that last hour before they go to bed to try to have no electronics at all. And if they did need to have electronics, there's things called blue light blocking glasses that you can get. So we really want to do a good subjective screening there. There are standardized assessments that we can do for insomnia. There's also, again, a rule out that we want to make based on the mental health history. So does this person have bipolar, depression, etc.? And has this person ever had a history of sleeping issues to begin with as well? These are all extremely practical questions to ask ourselves. Okay. Secondary insomnia, very similar type of methodology. One thing I've really learned over the time of working in mental health is that oftentimes primary care doctors will prescribe medications that actually conflict with the mental health medications that my patients take. So drug-to-drug interactions are actually a really important thing to consider. A great example of that is if any of our patients are on an atypical antipsychotic, so something like aripiprazole or Abilify, for example. So if I was suffering from some sort of like athlete's foot, I had ketoconazole prescribed to me and I was taking Abilify, basically the ketoconazole or any type of antifungal medication will basically quadruple the dosage of an atypical antipsychotic as far as a drug-to-drug interaction. So I like to really dive in and ask the patient, like, are you taking any new supplement? Are you taking anything different? And oftentimes you'd be surprised at how often that actually occurs. Like, are you taking a steroid, for example? Steroids will, basically cause insomnia in a lot of our patients. So ask those type of probing questions as well. Okay, so let's talk about if you've ruled this out and you need to treat it. So let's approach this and let's kind of talk about some options that we have. Okay, so the wellness approach, the holistic approach, consistent bedtime, exercise, temperature of when somebody is sleeping. I sleep really hot. Like I need some sort of cooling pad, or I can't sleep with blankets on me. Having a high core temperature is associated with lower quality sleep. So you want to be as cool as possible when you're sleeping. So a lot of people think that they want to be really warm and like in a warm blanket. You actually want to be the opposite. You want to be cooled down because your core temperature actually increases while you are in a deeper sleep. So then you can get into like a I'm too hot type of phase, and now your body's in kind of a fight or flight state because it's so hot. Be mindful of naps and oversleeping. We don't encourage patients to take naps during the day more than like a 20 to 30 minute. Some people, if they're used to taking like a siesta of a couple of hours, it's going to cut into their time of circadian rhythm at night. Go to bed a bit hungry. This is really important for our patients that have a high fat meal before bed. Like, let's say they have pizza and beer, and, now they're going to suffer from gastroesophageal reflux disease. They're going to have like basically acid that's building up in their esophagus before they go to bed. And that's going to be really uncomfortable and probably cause some insomnia. Here's some tried and true wellness recommendations. Aim for bedtime between 9 and 11. That's when our circadian rhythm is actually programmed to kick in. Don't do heavy food, don't do blue light, don't do any weight training or exercise before bed. Alcohol and smoking, caffeine and stress, these are all things that, again, we want to be careful and mindful of. I had a patient that came to me one time and she said, I want to go on Ambien. She's like, I've heard Ambien's the thing for sleep. And I was like, okay, well, hold on. I don't really like Ambien. I don't like that medication a lot. Let's talk about what you are currently experiencing, what's going on. So it turned out that she has 8 dogs that sleep in the bed with her. And basically her dogs are hyper alert. Any little sound, any like movement in the house, her dogs would go ballistic and like basically jump around and run out of the bed. So I was like, your problem isn't that you need Ambien, your problem is that you need to get the dogs like away from you while you're sleeping. So I think a lot of times people sleep with their pets in their bed, which again, pro and con. I would want to be close to my dog as well, but is that dog affecting your sleep is just the question that I would ask. This is like my preferred holistic supplement. So if anybody wants to have a really, really good quality sleep, I call this sleep juice. It's chamomile tea with whole milk. So I'll kind of explain the pharmacology of why I suggest this stack of supplements. So chamomile tea hits the same receptors as benzodiazepines. So Klonopin, Xanax, Ativan, Valium, these are benzodiazepine types of medications. Whole milk, when it's added to a warm liquid, so chamomile tea is warmed up, is going to release tryptophan. Tryptophan is the precursor for serotonin. That's going to put our body into a restorative and kind of relaxed state. Think of it like when we're babies and we have warm breast milk, that's going to help us fall asleep and feel more comforted. L-theanine is a great non-essential amino acid. It's found in green tea, especially matcha tea. So it's basically a really cool supplement that allows our blood vessels to relax, especially in our brain. It crosses the blood-brain barrier really well. Glycine is another non-essential amino acid that can only be really taken through food or through a supplement. That helps promote deeper sleep. And then melatonin, I recommend 1 milligram of melatonin or less. Most people, when they go to the store, probably find melatonin 3, 5, 6, 10. Your receptors for melatonin are actually not programmed to take any more than 1 milligram. I'll have a slide in a couple of slides that just explains the science of that. Again, there's a lot of misconceptions when people are having issues sleeping and they just kind of throw a brick at it, fix it. And oftentimes we're doing more damage long-term than actually help. And then magnesium supplements are super great as well. So if somebody has restless legs, I like to recommend Calm Magnesium or a magnesium ointment or cream. And if you rub that on your legs, it's transdermally absorbed through the skin. And magnesium is a great smooth muscle relaxer. It's also a great natural sleep aid. And again, people ask me questions like, why not lemon balm or valerian root or CBD or these other types of things? The reason I don't normally suggest these things is number one, drug-to-drug interactions. Like for example, with St. John's wort, there's a lot of drug-to-drug interactions with that. Ashwagandha, a lot of drug-to-drug interactions with that. Something like lemon balm, valerian root, there's not a lot of research that backs that up. So clinically, as somebody that wants to, be using the best science to recommend the best sleeping regimen to my patients, I want to make sure that I'm recommending things that are evidence-based and peer-reviewed, and everything up there is.
Seeing if I'm following the line correctly, would you recommend against a chamomile or like a green tea to start someone's day to feel to not feel as sleepy during the day? Or
so again, you can look at it from these are great to calm your brain down, but again, L-theanine is a really interesting supplement where if you combine it with caffeine, it actually works as like a stimulant. And if you take it without caffeine, it works as an anti-anxiety supplement. So taking a glass of chamomile tea or green tea to start the day off is totally cool. Anxiety is also a total killer of energy. So if you feel like you need that calm focus, that would be a great way to start your day. Yeah. We have some therapists in the room. I need to, of course, mention CBTI, cognitive behavioral therapy for insomnia. If any of the therapists in the room are not certified for CBTI, I would highly recommend you look into getting the certification. It is probably the #1 demanded psychotherapy recommendation that I have for any patient, because insomnia is so widespread. 1 in 3 adults have it. Women predominantly have more. CBTI would be a great therapeutic skill to pick up if you haven't already. And then, of course, distraction, mindfulness. One thing that I personally do if I'm having trouble falling asleep is I imagine a wheel that is spinning, and then you follow it with your eyes while you're laying in bed. So this follows the principles of EMDR, follows the principles of like basically causing your mind to kind of disassociate with like the reality around it. So you close your eyes and just imagine following like the wheel of fortune wheel going around. And it's super relaxing, and you kind of forget, I can't do the counting sheet. I can't do that type of method. So that's my method that I use.
If you jump up and say, big money, it's not working.
Yeah, it's not working if you're jumping up and saying that. And to speak more, so on my passion and what I'm really good at is the psychopharmacology around treating insomnia as well. Effective psychopharmacological treatment for insomnia. It's kind of the Goldilocks principle. You need to get it just right. Really hard to treat insomnia with medications because you can go too hard and you can go too soft in terms of how aggressively that you're treating it. So oftentimes when you're trying to treat insomnia, you want to give a range to your patient in terms of what they can safely take and let your patient adjust the doses appropriately. So for example, if I was to prescribe trazodone to somebody, I would basically start at a 50 milligram, but I would give the person an option to take 25 up to 100 at nighttime for insomnia, because I don't want them to call the office the next day and say it didn't work. And then I want them to have a little bit of time to experiment with that medication and see if it could work. So it's really hard to kind of know this. And we mentioned melatonin a little bit before. 1 milligram of melatonin is the appropriate amount of melatonin to take. If you're taking a melatonin supplement that's more than 1 melatonin, you're oversaturating your melatonin receptors. Your body actually can't absorb them enough. So this was actually like very well studied. Oftentimes a lot of the melatonin that's sold is just too strong. It's kind of the American culture, I think, to just kind of bomb something until it's, not there anymore. And that's kind of what we're doing with melatonin treatment is by the time that the 1 milligram is absorbed, if we took a 3 milligram, it's just like continuing to cascade on the receptors. It's kind of wearing those receptors down. So we definitely want to make sure that we're being targeted in terms of that. So another option that we have for insomnia, this is a great option clinically, is blood pressure medications. So the theory is if we can lower somebody's blood pressure, we can induce relaxation, especially in the peripheral vasculature. That's a really great holistic, more focused way of treating for sleep. So we have alpha-1 receptor blockers, we have alpha-2 receptor agonists. This is a really interesting class of medications here, the A1 receptor blockers. You may recognize Prozostin or Minipress. We use these for nightmares. We also have a medication called doxazocin that I train my providers to look out for as well. So the half-life of Prozostin or Minipress is about 2 to 4 hours. So if I was a combat veteran that suffered from nightmares, I don't want coverage for my nightmares for 2 to 4 hours. I'd rather have all day coverage of hypervigilance and nightmares and so on. So doxazocin or Cardura is a really well-known medication in the prostate world, but not necessarily in the nightmare and sleep world. So there's definitely like lesser known medications that if you guys take note of these slides, you may definitely learn from some of the really good options that are out there. There's also melatonin agonists. So one of my favorite medications to pull from is called Rosarum or Ramelteon. That's only available in one dosage. It's an 8 mg dosage, and it's melatonin agonist, low side effects. It's basically the perfect amount of melatonin delivered to the receptors at the right time. This helps us reset our circadian rhythm. There's another medication called Hetlioz, which has a very similar mechanism of action. And then, of course, we have melatonin over the counter. This is our most natural type of sleeping aid to suggest to somebody because it mimics what our body is already producing naturally. But we now have two prescriptive options that are very similar to each other, but often great M1 and M2 melatonin receptor agonist effects. Okay, now we have benzodiazepines. This is a tricky class because they're very effective, but we don't get the best quality of sleep long term from taking benzodiazepines. So I've put some notes on each benzodiazepine here, so you may have seen these names before, but these are basically used for acute insomnia. So benzodiazepines are the gold standard of treating postpartum depression because typically postpartum depression is caused by acute insomnia after the child is born. So there are like really important reasons to prescribe benzodiazepines. Maybe somebody has a chaotic life event that they're going through, but you want to try to limit your prescription for benzos on a daily basis to around 3 months or less. Oftentimes people get a little bit lazy when they prescribe, and then they just say, okay, well, it's working, and come back and see me, and we'll just keep refilling it. But we're not really getting to the core of what that person's sleeping issues are being caused by. And it's a little bit of a lazy prescribing methodology to just rely on our benzodiazepines to help somebody induce sleep. We also have over-the-counter treatments. I have a little bit of information here about antihistamines. There's first and second generation. Of course, you can use things like Benadryl over the counter to help us sleep. Things like Unisom, Visceral, and Atarax. These are all really common as well. Again, similar to benzodiazepines, I don't recommend people take antihistamines for a long period of time either. Antihistamines are associated with drying the brain out, and more dementia and Alzheimer's over time as well. So especially for our geriatric population, we definitely don't recommend long-term prescription of antihistaminergic types of medications. So things like Visceral and Atarax, which are commonly prescribed as kind of an adjunctive for anxiety, we definitely don't recommend in an older population, or in general, I try to stay away from those as well. These are hypnotics. You've heard of Ambien before, I'm sure, and Lunesta is the newer prodrug version of Ambien. It's a little bit better side effect profile wise, but hypnotics all carry with them withdrawal side effects if you were to have somebody on that medication for a long period of time and they were rapidly to discontinue. And Sonata is another example of a rapid onset one as well. These are all effective, but carry with them a little bit of that same benzodiazepine class warning. This is a newer type of medication. It's called an orexin receptor antagonist. So Balsamra, Dayvigo, and Quviviq are the 3 medications in this class. All of them work a little bit differently. Basically, this is how long the duration is that they work. So Quviviq is an example of something that basically is you have to have your patient get a minimum of 8 hours of sleep. If they can't get 8 hours of sleep, they're going to wake up and feel extremely groggy. Something like a Dayvigo or a Balsamra doesn't really have that same kind of warning. These are really good medications to look at because they're non-habit forming. And whereas Ambien, the way pharmacologically I can describe Ambien is like you're coming up to a stoplight and you're slamming on your brakes right at the stoplight. An orexin receptor antagonist is like easing on your brakes to come to a slow stop. So it's not like going to induce sleep really fast. Some people think that sleep has to be like, I take my Ambien and I go to sleep in two seconds. It's not good for the body. We want to kind of like ease into sleep. These medications, this class is really good for that. We also have antidepressants. So we have TCAs, we have medications like trazodone, we have medications like doxepin and imipramine and Afrinil. I love TCAs. I know that there's a big kind of fear of TCAs due to QT prolongation and some of the side effects that occur there. But I see so many benefits of TCAs downstream, and if you actually look at the research, TCAs are performing way better than SSRIs in a lot of cases as well. I like killing as many birds with one stone, kind of, as the saying goes, as I prescribe medications. If I can find a medication like amitriptyline that can help somebody for insomnia, can be a migraine prophylactic medication, can help with fibromyalgia, can help with anxiety, can help with depression, and basically take care of 5 potential differential diagnoses with one pill. That's my preferred medication. So that's kind of how I think as a prescriber is like, what is a way for me to reduce the medication burden for my patients as I start to think of what receptors I want to activate. And then we have atypical antidepressants, Remeron and trazodone, the 2 here to mention. One note about Remeron, lower doses actually work better for sleep. So this is very counterintuitive, and this is something that we have to train our prescribers on. Typically the starting dose for Remeron is 15 milligrams for depression. For sleep, I would recommend people start at 7.5 milligrams per Remeron. So the lower doses are actually better. The reason for that is as the dose increases, it actually activates more of a norepinephrine effect. And norepinephrine is like our fight or flight molecule. So if you can think about that, it's basically putting a gas pedal down when we're trying to have it induce sleep. So 7.5 is my starting dose for sleep.
How, explain to me how in an SNRI then the norepinephrine is effective, and that I know it's out, people are questioning whether or not it really is helpful for the treatment of anxiety, but I never have really gotten that.
So you're saying like, why is it that we would do an SNRI for treating anxiety?
Yeah.
Because basically you're saying norepinephrine is like a fight or flight molecule, so
Right.
wouldn't it stand to reason that that would potentially make the anxiety worse?
That would be, my logic would say that. Yeah.
I agree with you.
Yeah.
So I agree with you, but I would counter that.
Yeah, I don't take them, but.
Yeah, I would just counter that all anxiety is not necessarily related to kind of a restlessness.
Right.
Sometimes anxiety is because you don't have the gumption to get out of bed and do stuff.
Yeah.
So sometimes you can cure anxiety with a stimulant, for example.
Mhm.
So it's like you have to understand the pathophysiology of like where that anxiety is deriving from. Is it anxiety because they like feel restless, which is again where I would say you're correct. I wouldn't necessarily recommend noradrenergic type of agent. Or is it that they can't do things, they feel tired all the time, and then they kind of mentally beat themselves up
Right.
because they can't, right?
Yeah.
So that's kind of like where the nuance of prescribing comes in.
Gotcha.
Is it like counterintuitively is kind of there, but it also makes sense.
Yeah.
You know what I mean? Typical antipsychotics and atypical antipsychotics are next. I would probably not recommend typical antipsychotics to induce sleep. I have had to use typical antipsychotics in like some extreme cases for folks that have bipolar that isn't controlled and they have insomnia from that, but not very typical at all. And then atypical antipsychotics, we have Zyprexa and Seroquel and Risperdal and some of these as well. These are great in low doses. Definitely would prefer to use things like orexin receptor antagonists instead, but these are again options that we have for folks that suffer from mood disorders on top of the insomnia. Okay, and then last slide before we open it up to questions, and anybody that's on the Zoom call can feel free to ask questions as well. Sometimes we have to get creative. So we have mood stabilizers. Sometimes I use muscle relaxers to help somebody fall asleep. So sometimes like a baclofen, or sometimes like Flexeril or tizanidine. Again, if somebody is having insomnia because they have like chronic jaw tightness, or they have insomnia because they have chronic back pain, like you again have to kind of get to what is the patient saying. So mechanistically, what is the key that I can use to unlock whatever symptom that they're kind of complaining of? That's at the core of it. Where the psychopharmacology exists is you have all these tools in your toolbox, but you have to use the tool to the patient's best interest, and you can't just do a one-size-fits-all type of approach, because it could be that this patient would be best if I did like a trazodone because maybe they had comorbid depression, anxiety, that antidepressant would be the best sleeping agent. But maybe this other patient is, I have TMJ, and my jaw is hyper locked up all the time, and
Tizanidine.
exactly. Does that make sense in terms of how like a prescriber should kind of think through that thought process of medication? And anyway, this is where sometimes we have to get creative, use mood stabilizers and so on. Neurontin, Lyrica, restless legs are a common reason why people have insomnia. So these are, again, where we sometimes have to just think outside the box. But that was my overview of insomnia, circadian rhythm, REM sleep cycles, primary, secondary, and actual treatments for it. So I'd like to open it up for questions. We have about 10-15 minutes for people. Ask any questions that they have burning in their brains. That was a really good question about the norepinephrine. Yeah, it's really counterintuitive sometimes. Yeah.
And I'm keeping an eye on the chat in case anything's happening right now.
Yeah, sure.
Welcome to the room to ask all questions.
In your experience, does time release melatonin work?
Time release is good, yeah. You don't want things that cascade and overload the receptors. You just want things that basically are longer. I would prefer sublingual and liquid melatonin myself. So it's actually the pediatric version of it. It's the 1 milligram or less that you'll find. And it's pretty remarkable how like effective that'll actually be. I prefer sublingual and liquid when I can because it doesn't pass the blood or it doesn't pass the first pass effect in the liver. So when I swallow an oral medication, the first thing that happens is that medication goes from my mouth to my esophagus to my stomach. It's absorbed through my stomach wall, and then it goes through the liver. So any oral medication has this biopharmacology. And then 50% of that medication's effectiveness is eliminated immediately. That's called the first pass effect. So if I took 10 milligrams of melatonin orally, then it goes through the liver and I only have 5 to work with. So that's where I like sublingual liquid types of medications because it bypasses the first pass effect. So if I take a full dosage of the medication, it's the true full dosage of the medication as opposed to just cutting it out immediately.
You mentioned the GABA receptors and all, and how some medications, you know, bind or whatever with that and help with sleep. But would all of these treatments also be recommended in, say, insomnia related to PTSD?
Some would, some wouldn't.
Mhm.
An example of that is I wouldn't necessarily recommend chronic benzodiazepine use
Right.
because you want people to have the dreams, you want people to have the experience of experiencing the anxiety as opposed to suppressing it. An example of where that would come into play is like your alpha-2 receptor, or alpha-1 rather, like the mini press or the doxazosin. That's where you can flex it for both insomnia and PTSD. You'd also want to, again, strategically align yourself with other medications, not just related to insomnia, but an example of that is like iloperidone or Fanapt is an atypical antipsychotic that has a really strong alpha-1 receptor blockage profile to it. So if I was building a regimen for somebody that has PTSD, I'd want to stack multiple medications that basically kind of support that alpha-1 receptor blockade. So I'm kind of thinking strategically down the line of, okay, this is their primary issue, I want to stack medication to support it there.
You see 2 questions in the chat. For the first, Miss Lynn, I see your hand is up. I'm going to turn up my volume so we can hopefully hear her question. I'm going to turn it back down for your response just so we don't get the feedback.
That's cool.
Can you hear me okay?
Yes.
I've kind of developed 2 questions. Number one is when working with people who have nightmares, especially veterans, but anyone who is having chronic nightmares, how do you differentiate and what would you like to see as far as clinicians go? Like when to refer for the chronic nightmares versus letting people have the experience of the, the anxiety, the trauma effects. Like, how do you differentiate when is a good time to refer to the medications? What would you like to see us do? Oh, and then the second one is, do you work with kids?
Yeah, so, oh, sorry, I'll let you turn that down so we'll get feedback. The first part of the question was if we have somebody that has nightmares, do we want them to basically like experience those nightmares? I kind of briefly mentioned this before with clonazepam and benzodiazepine part of the question. A healthy amount of processing of any symptom is really, really good. You should experience some sort of stress or stress. You have to know depression to know happiness. You have to kind of know the different ends of things. So there is some truth to that. I would say as long as it is not impacting their quality of life, it's not impacting their sleep duration, their amount of energy. They should be able to be okay without medications, but I would say in probably 90+% of those cases, you're probably getting downstream effects of where those nightmares are causing chronic anxiety during the day or hypervigilance during the day. And in that case is where I would definitely want to involve a prescriber, because we can co-manage that case with you a lot closer, of not trying to suppress the symptoms altogether, but manage the symptoms around as you're exploring maybe EMDR therapy or exploring kind of the healing process of that. We definitely want to be a supportive member of that team. So if you kind of trigger something in therapy, they don't have to wait the time, and you don't have to delay further treatment and further sessions of EMDR as you kind of unpack that. And then on the kids side of things, we don't see any kids under the age of 18 right now. However, we're actively working on adding a pediatric arm to the practice. So that should be here, and hopefully by year end.
Thank you.
And the other question in the chat was, do you work with patients with dementia, and how can one refer clients to you? So
That's a good question too. So we actually have an arm of our company that does long-term care facility work as well. So we do round in assisted living facilities and memory care units. So that's called iTrust Cares. If that person has any more questions or information about Jerry Psych kind of arm or company, Anna would probably be the best person to answer that for them. So we can certainly get them contacted.
and yeah, that's correct. Ms. Suhaimi is Jerry Psych. Or if you have questions about Jerry Psych, and we'll make sure that your contact information is shared for iTrust, certainly. So those are the only questions I'm seeing in the chat here. So
I do know that there was questions about if you were okay with me sending out the presentation when I do.
Yeah, 100%. Yeah.
And if it's okay, just while I have everyone's attention for those who did not hear. If you register for this seminar, I will be sending a follow-up email that will contain digital copies of all of our marketing materials, as well as the presentation that was given today. We also have a psychopharmacology guide. I'm sure many of you have seen that on LinkedIn. Steve has been great about sharing that. If you would like to order any physical copies, I will also include information in the follow-up email on how to do that. So if you want to just keep an eye out on your inbox, I will be sending that probably a little bit later this afternoon.
that'd be great. Thank you for that.
Yeah, thank you for everybody attending. This technically is a CME presentation, so you may be able to get some credit hours for it, but I appreciate your guys' time, and hopefully you learn something.
Thank you for your time.
Thanks so much.
Thank you.
Thank you.
Just before we end all the way, I just have a couple slides I can share with you all here for MHA. And so thank you for mentioning CME or CE in our case. We have the QR code available for those watching on Zoom, and we have it in person here for you all if it's necessary. But just want to thank you again, Steven, and certainly iTrust for partnering with us. Fantastic presentation, fantastic information for all folks who attended. And as always, from the MHA Spartanburg side of things, just always want to thank our friends, our supporters, as well as our sponsors, which is Susan Lee Therapy, Spartanburg Regional, Regenesis, Carolina Center for Behavioral Health, Life Stance Health, the Forrester Center, and Connect Spartanburg. Our next Ed series will be in July. We'll be sending more information on that very shortly. We did record today. Thank you for that permission to do so. That'll be up on our YouTube channel, typically within 24 to 48 hours. We also have set our date for their 10th annual symposiums. This will be on October 22nd this year at the Piedmont Club. And we'll send out award nominations for that. We give out 4 awards with this symposium, so we'll send that out shortly to folks who may have someone to nominate for that. But we are right on time today at 1 p.m. So thank you all again for attending iTrust and to Steve for presenting. So thank you all.